Hello everyone, and welcome to Healthline 3. I'm Terry Simmons, and I'm joined today by Dr. John Winterton of Willis Knighton Pierremont Cardiology. And if you have any questions for Dr. Winterton, you can call the number you'll see on your screen throughout the show. That's 318-219-4569. And just so we can hear your questions and get them answered for you, make sure you're in a quiet room and your TV is turned down before you call in to speak with the doctor. Hello, Dr. Winterton. How are you?
Great, thank you. Thank you for the opportunity to be here.
Oh, we're so happy to be talking to you today. Now, before we get started, we were talking earlier. I'm a hometown girl, just came home. You're also hometown, come home. So tell us a little bit about your history. Your family history is wonderful, and about you being here.
Thank you. And I grew up in Shreveport. My dad was a pediatrician here for 40 or 45 years, and I went to Jesuit High School, and when I graduated, went to the University of Notre Dame. And then went and spent 10 years in New Orleans and went to medical school at LSU and did my residency and fellowship there. And then I went to Lake Charles, Louisiana, and practiced for 25 years. And very, very pleased to be home and excited to be at Willis Knighton in a great system. So it's a great honor to be back here.
Well, we're happy to have you back here for sure. And we thank you so much again for spending your time with us today. I know your family's happy to have you here. Everybody's happy that you're here. And we would like to talk to you a little bit about congestive heart failure today. We were talking earlier about how that's a misunderstanding and some people might not realize. We talked about it earlier in the day today too. Heart failure doesn't necessarily mean that your heart has stopped. What would you tell someone?
That's right. Congestive heart failure is one of the two most common diagnoses that we see, problems that we see in the cardiology office and in the hospital. It has negative connotations. It sounds awful, and unfortunately people take it as such. The good news is that that's not really true. There are a lot of options in treatment, and the prognosis is not always grim. Heart function is the single biggest determinant of outcomes relative to heart disease, and people who have heart failure certainly have serious concerns relative to the way they feel, their activity tolerance, but also their longevity. And so it is a serious matter. It is something that has to be investigated and a treatment plan developed to certainly prolong longevity, but also improve quality of life.
Okay.
Good news is we have the options out there to achieve that.
That is good news, and all right here, right, accessible to all of us. And I think we have a caller. Her name is Marilyn. Marilyn, can you hear us? And what is your question?
Yeah. Hi, doctor. I was diagnosed with diastolic heart failure after having COVID in February. I was diagnosed by my primary care physician, and I was just wondering, he never told me or referred me to a cardiologist. Do you think that I should see a cardiologist?
So there are a couple of interesting points in your question. One is that is important to highlight is that if something is not right, if you're feeling short of breath, you're weak, not tolerating your activities, that you seek the attention of your primary care doctor. That unquestionably is the appropriate thing to do. So you did the right thing there. You also brought up an interesting topic of so-called diastolic heart failure. As it turns out, there are two categories of heart failure. One in which the heart function is poor. In other words, the heart as a muscle is weak, it doesn't pump well, and the result is that the rest of the organs in the body do not receive the appropriate blood flow. But more noticeably, the blood flow backs up in the system. You develop the symptoms which are characteristic of heart failure, which is shortness of breath and decreased activity tolerance, swelling, etc. That's typical of patients who have poor heart function, where the heart doesn't pump well. In your case, you identified that you had so-called diastolic heart failure, which is a somewhat more complicated conceptual topic. But the bottom line is, with diastolic heart failure, the heart pumps well, it squeezes well. The actual problem is that the heart won't relax properly. And unfortunately, it's poorly recognized that over half, or close to half, in any case, of the patients who have heart failure have diastolic heart failure. The other unfortunate fact is that people fail to realize the severity or the significance of it. The morbidity, in other words, the likelihood of complications from heart failure from either cause is the same, and so is the mortality. So diastolic heart failure, as you identified, is a very serious matter. And so, yes, I would suggest that you see a cardiologist at the direction of your primary care doctor to get a clear diagnosis and develop a formal treatment plan that gets you out of the higher risk categories of patients.
Hey, Marilyn, does that answer your question?
Yes, it does. Thank you so much.
Oh, thank you so much for calling. You know, the great things about people calling in too, be sure and call in, because like just Marilyn asked that question, I just learned so much myself. So when anyone calls in with a question, chances are we're all going to have some, you know, some questions answered too. So it's really helpful when they do that. And so
gives the opportunity to identify some features that people don't ordinarily recognize. That concept of diastolic heart failure, roughly 26 to 28 million Americans experience heart failure in the United States annually.
Really?
Substantial number. It's divided about half and half between systolic heart failure and diastolic heart failure. And that's where the work begins, is identifying what is the cause, where does it come from? Is it poor muscle function? Is it the heart's weak? Or is it that the heart's not relaxing? And the causes of those two are somewhat different. As relates to COVID-19, it's a little hard to know. We don't have that very well pinned down in terms of the things that we see from the cardiovascular standpoint. But on a general aspect, from the general aspect, the two entities of heart failure are well described, and the workup and the treatment are somewhat different. As I said, unfortunately, the prognosis is similar.
Okay, very interesting.
You know, it's crucial to understand the communication that's involved between doctors and patients.
Right.
In my view, that's the single most important part of practicing medicine. And under the very best circumstances, it's difficult because the amount of material that's involved in what we're trying to apply to a certain patient's complaints is massive. I have a son in medical school who called just last night to inform me just how hard it was to try to remember all the things that he's being asked to remember. And I told him, I said, it's akin to drinking from a fire hose. But each and every ounce of that material is critical. While you're talking to patients, all of that material then has to be put into play and then conveyed back to the patient in a fashion that is understandable. And that's a real challenge, particularly given the strain that patients are under just showing up in the doctor's office.
Yes.
A lot of people experience the phenomenon that their blood pressure is sky high when they show up in the doctor's office. And we're learning, it seems crazy, but we're learning today that actually we are probably better off watching blood pressures that are checked at home for that very reason.
Right.
Well, that's a minor problem on a relative scale as compared to heart failure. And so you can imagine the heart failure patient's perspective and ability to hear and understand what's being described. We work really hard at trying to achieve that, but it's certainly not perfect. But I think it's a very important point that she makes relative to our perspective, but also that of the patient, and making sure that we're aware of what's going on.
Right. That's a lovely understanding. And I think we have another caller. Christopher?
Hi. I wanted to ask, my dad was diagnosed with congestive heart failure with cardiomyopathy. And I don't know what cardiomyopathy is. I was just wondering how they linked up, and if one was the cause of the other.
Sure. Actually, the term cardiomyopathy is a much nicer term from the standpoint of its connotation. So when we talk about heart failure, all we're saying is that the heart is not pumping well or not performing ideally. What causes the heart failure then is a cardiomyopathy. Cardiomyopathy just means abnormal function of the heart. In the case of reduced heart function, in other words, a weak heart, the heart doesn't pump well. In the case of the previous caller's diastolic heart failure, the heart doesn't relax. But in both of those cases, those are cardiomyopathies. In other words, the heart just not performing normally. Cardiomyopathy, when you have a cardiomyopathy, a heart not performing appropriately, then you can have congestive heart failure, which is the collection of symptoms and physical findings that are associated with poor heart function. Cardiomyopathies are broad in terms of the causes, and that's where our job comes in, to sort out exactly what it is that caused the cardiomyopathy, the poor heart function or dysfunctional heart activity. If you look at the patients who have poor heart function, the most common cause would be coronary artery disease or blocked arteries, inadequate blood flow to the heart. Heart's a really interesting organ. The heart is a muscle, just like any other muscle in your body, and that muscle requires blood flow to do its job. And in the case of the heart, most people would think that the blood inside the heart chamber takes care of the heart muscle. But in fact, that's not the case. The heart is supplied by 3 small arteries that run over the surface of the heart. The blood then has to run back through those arteries over the surface of the heart and down into the muscle to feed the heart. It's those 3 arteries that develop cholesterol plaque and then become narrowed and can cause heart attacks, or it can be a slow progression of poor blood flow, both leading to cardiomyopathy, in other words, the heart not pumping well. In the case of artery disease, the risk factors for that would be diabetes, high blood pressure, high cholesterol, inactivity or so-called sedentary lifestyle, a family history of heart disease, and smoking. And if you had to identify 10 risk factors instead of 6, probably the first 5 would be smoking. But those are the causes. And then on the other side of the table, the diastolic cardiomyopathies are caused by other interesting components, but artery disease can contribute to that. Diabetes and high blood pressure are probably the main issues. So that's a long-winded explanation, but cardiomyopathy is simply the heart not working appropriately because of some cause, leading to what we call heart failure, which is the symptoms.
Okay, thank you so much for your call, Christopher, and our best wishes to you and your family. And I think it's something too that occurred to me while you were talking, that we talk about the heart pumping the blood to take care of everything else, but the heart also has to be fed. The heart has to be taken care of. It's using the blood and everything too. And speaking of that, we have a couple of callers on the line. Well, first we're going to go to Elizabeth.
Yes. The little lady that called in earlier, I understand her having to wait 3 hours in the waiting room, but what people don't understand is these specialists sometimes get called in to do emergency surgery. And if you're the one on that table having the surgery, you would be more likely to understand why it took so long. Thank you.
Yes, ma'am. That's a well taken point. We certainly do everything in our power to be where we're saying we're going to be at any given time. There are lots of responsibilities that often are outside of our control, and I can assure you that your doctor is working hard to try to get where he's supposed to be. But that is true. There are things that are more than distracting. They're require our undevoted attention.
Absolutely, and there's no schedule to saving lives and things that come up where you're needed, and to be able to focus on that and do that is quite a miracle. Thank you very much for that. And I think we have someone else. Gwen. Hi, Gwen.
Hello, how are you? And thank you.
Good day.
Thank you guys for taking my call. And just a real point, I really love the Willis Knighton system. I've been in it for a while, and I think you guys do a great job. But I wanted to know, my grandmother passed away years ago, and that's when she passed away with a heart attack. My mother's mother. Is there any type of chance that any of the siblings, my mom, kids can develop things like that, heart problems?
Yes, ma'am. Thank you. We're very proud of the Willis Knighton system and work really hard to try to achieve high quality and patient satisfaction. In terms of the heritability of heart failure or causes for heart failure, yes, there are some issues that are related to familial history. If you take and divide the two types of heart failure, if you look at principally at the type of heart failure caused by a weak heart, there are certainly people who have a familial history that is genetic. I would tell you that that is rather poorly understood and also rather unpredictable. That does exist, and it certainly is a question that we ask when we talk to patients who have had heart failure. The coronary artery disease side of it, the blocked artery part of it, has within that aspect of heart failure or aspect of development of poor heart function, cardiomyopathy, the family history and propensity to develop cholesterol plaque within arteries. And so sort of on two levels, family history does play a substantial role in the development of heart disease. That's not to say that you should be afraid of that, because it takes usually more than just the family history to develop heart disease. The other part of the story is that there are lots of things to do about it and ways to keep yourself out of trouble so as to, so to speak, duck the family history. And what can you do? Well, take care of those things that are causative, such as diabetes and high blood pressure and high cholesterol. And as I mentioned earlier, stay 50 miles away from the nearest cigarette. And if you do those things and see your doctor regularly, most people will do just fine, and it's not something to be feared.
Thank you for your question. Did that answer? Do you have anything else you'd like to ask the doctor?
Yes, you're real fast, and thank you. I'm sorry. What is the possible percentage of that happening?
I'm sorry, I didn't catch the.
What, can you repeat your question,
What is
please?
the possible percentage? What is the possible percentage of the siblings developing the heart condition?
I don't think we could tell you the answer to that question. Not high it would be the general answer to the question in terms of the likelihood of developing heart failure. Do we see it? Yes. I would say uncommon, and to put a number on it would be unfair. But again, it's not something I would sit around worrying much about, other than tend to the things that are treatable. You certainly can't undo the genetics, but you can absolutely do something about diabetes or preventing it, as well as treating it. You can certainly treat high blood pressure. Roughly 50 million Americans today have hypertension.
And we have both of those in our family, the diabetes and the high blood pressure.
Yes, ma'am, and that's very important to know. We can identify that 50 million people have high blood pressure. It's the massive number of people that we don't know that have it, maybe never know that they had it, and they show up with big problems, and it's too late.
Okay.
So take care of those things. That's the key. See your doctor.
Yes. And thank you very much, okay?
Yes, ma'am.
Oh, we thank you. Thank you so much for watching and for calling.
All right.
So there are things, even if you feel that it's, you know that it's been in your family, you're told something, if someone does tell you a percentage either way, there's still things, no matter what, that you can do to take care of yourself in that and maybe never experience it.
So there are two things to know. One is that certainly if you pay attention to your risk, such as diabetes, high blood pressure, smoking, family history, high cholesterol, all those things, if you tend to those things, and that's done by seeing a family doctor and paying attention, doing what you're directed to do, you can go a long way toward preventing the problem. Once heart failure develops, then seeing your doctor and finding out exactly why the heart failure exists, why you're short of breath, why you're having the inability to perform activities as you want, why you're having swelling, and then having that worked up. Make sure that they're not blocked arteries. Make sure that they're not problems with heart valves. Treating high blood pressure and diabetes. And then lastly, there's really good news in that we have lots of therapeutic options, lots of new medicines. Just in the last 3 or 4 years, there have been the development of a couple of medications, which is the first time in maybe 20 years that we've had substantial innovation in medical therapy to treat heart failure. And as part of that, we can also say that we have found things that increase lifespan for those patients. Increased lifespan, increase the chance of staying out of the hospital, and reduce the chance of having symptoms. In other words, improving functional class. And that simply means improving quality of life.
And so what's an example of a medical therapy that you're talking about?
Well, there's a couple of new medications. Probably the single biggest innovation was a drug called Intresto, which is in a new class of medication, similar to some medicines that we've been using for about 25 to 30 years, but has been shown recently to be superior in terms of the quality of performance and the improvement in quality of life, but most importantly and very clearly capable of prolonging life beyond the previous standard care and reduce the chance of being in the hospital, etc. So that's one example of a medicine. There are lots of other things that are being done mechanically, certainly fixing blocked arteries, and on a day-to-day basis there are new innovations to fix coronary artery disease. In our practice, we're doing all of those things, stents and stenting arteries that are simply moderately blocked to severely blocked, but also opening arteries that have been blocked for a long time. We call those chronic total occlusions. And then beyond fixing blocked arteries, new heart valve therapies for that group of people who have heart failure because of narrow heart valves. In that group are what we call TAVR, which is simply replacing the aortic valve going through the artery in the groin, as opposed to having to have a major open heart operation. And then if you carry that out further, the bigger advances and more complicated advances involve assist pumps. There have been new pumps developed to help people who are in the throes of really serious heart failure, life-threatening circumstances, that we can implant at Willis Knighton, and on a more prolonged or protracted basis, the development of left ventricular assist devices, which are in continual evolution. Currently, they require an exteriorized or a line that comes out of the skin attached to a motor, a pump. But with time, that's going to the ease of use of those devices is going to increase, and we hope to be able to offer those right here in Shreveport.
And that's really the good news. All of the things you've been talking about are available to us right here in this area, and there's no more of having to travel long distances to really get this kind of care and take care of yourself, and that's really a comforting thought too. So a little bit about, is there any early onset? Do you see early onset of heart failure, and is there a way to recognize that if someone is really, they think they're too young to have that, they're having these symptoms? Do you see much early onset of heart failure?
That highlights a really important point. We classify heart failure in different groups. The New York Heart Association classifies it from 1 to 4. 1 as basically not recognizable, 2 being someone who has reduced activity tolerance but can still function. In other words, they get short of breath when they climb the stairs or if they're at work or doing heavy activities. The class 3 patients are the people that we often run into having to go to the hospital from time to time, really short of breath with minimal activities. And then the class 4 patient is somebody who's stuck in the hospital basically. The problem being that the consequences of heart failure exist in both the class 2 and class 3 group. And so it's critical to recognize those symptoms. Shortness of breath is probably the most common, and shortness of breath comes in a lot of different ways, believe it or not. It's not just that I'm huffing and puffing, but it's that, golly, I can't get up the steps, I can't make the bed, I can't do my laundry, I can't cut the grass. It's fairly ubiquitous. We talk a lot about differences between men and women, but if you generalize it, a decreased ability to tolerate activities. And in the more full-blown form, it's really short of breath, swelling in the legs that's unexplained, are the things that people most often notice.
Okay. So anything else you think, we only have a few more seconds, but I'd like to ask you, is there anything else? We covered a lot today, and it sounds really, really good, really interesting, and I appreciate it. Anything else you really want our viewers to know before we say goodbye?
Well, I think it's important to make sure that you recognize the symptoms of heart failure and get attention, both through your primary care doctor, but also your specialist as referred. Take your medicines, ask the questions so that you understand the why. It's always critical to understand why. And know that we at Willis Knighton are available to help you at any point.
Always available. Thank you so much for taking time with us, Dr. Winterton. It's been a pleasure meeting you.
Thank you very much.
And everyone else, thanks for calling in. Thanks for viewing. You take care, and we'll see you next time on Healthline 3. That really was. Thank you, Nina. Thanks, everybody.
Good. Thank you.
That was really, really great. Thank you so much.